10 questions. Mechanics of breathing. Pause after each question if you need time to think. Let's go. Question 1. Compliance is defined as A. Pressure divided by volume. B. Resistance times flow. C. Volume divided by pressure. D. Flow divided by pressure. Pause if you need to think. The answer is C. Volume divided by pressure. Here's why. Compliance describes the distensibility of the lungs and the chest wall. The equation, compliance equals change in volume divided by change in pressure, C equals delta V divided by delta P. High compliance, a small pressure change produces a large volume change. The lung is easy to inflate, like a compliant balloon that stretches easily. Low compliance, a large pressure change is required to produce even a small volume change. The lung is stiff, hard to inflate, like trying to blow up a paper bag. Compliance is the slope of the pressure-volume curve. Steep slope, high compliance. Flat slope, low compliance. Normal lung compliance, approximately 200 milliliters per centimeter of water. Increased compliance, emphysema. The alveolar walls are destroyed. Lung tissue is less stiff, easier to inflate, but the lung has lost its elastic recoil. It cannot drive expiration effectively. Decreased compliance, pulmonary fibrosis, pulmonary edema, ARDS, atelectasis. The lung is stiff. High pressures needed to inflate. Increased work of breathing. In anesthesia, compliance is what you feel when you manually ventilate a patient. A stiff bag that won't compress, low compliance. A bag that inflates easily, normal compliance. Question 2. At functional residual capacity, A. The lungs want to expand and the chest wall wants to collapse. B. The lungs and chest wall both want to collapse. C. Lung recoil inward equals chest wall recoil outward. D. Intrapleural pressure equals atmospheric pressure. The answer is C. Lung recoil inward equals chest wall recoil outward. Here's why. FRC is the equilibrium point of the entire respiratory system. Think of the lung-chest wall system as two springs opposing each other. The lungs, at all volumes above zero, want to collapse inward, elastic recoil. The surface tension of the alveoli and the elasticity of lung tissue pull the lung toward collapse. The chest wall, at volumes below its natural resting position, wants to spring outward, outward recoil. FRC is the volume at which these two opposing forces are exactly equal and opposite. The lung's inward pull, balanced by the chest wall's outward push. Net force, 0. No active muscle contraction needed. Passive equilibrium. This balance creates the negative intrapleural pressure, approximately -5 centimeters of water, that holds the lungs open against their tendency to collapse. The clinical implication: anything that disrupts this balance changes FRC. Decreased lung elasticity. Emphysema. Less inward pull. Equilibrium shifts outward. FRC increases. Increased lung stiffness. Fibrosis. More inward pull. Equilibrium shifts inward. FRC decreases. Pneumothorax. Air enters the pleural space. The negative intrapleural pressure is lost. The lung collapses inward. The chest wall springs outward. The balance is destroyed acutely. FRC, equilibrium. Inward lung recoil equals outward chest wall recoil. Question 3. According to Laplace's law, alveolar collapsing pressure is A. Directly proportional to radius. B. Inversely proportional to radius. C. Independent of radius. D. Directly proportional to compliance. The answer is B. Inversely proportional to radius. Here's why. Laplace's law for a sphere, pressure equals 2 times surface tension divided by radius. P equals 2T over R. The critical insight: pressure and radius are inversely related. As radius decreases, pressure increases. Small alveoli have higher collapsing pressure than large alveoli. Think about what this means without surfactant. A small alveolus, high collapsing pressure, would empty into a connected large alveolus, lower collapsing pressure. The small alveolus collapses. The large alveolus overdistends. This is exactly what would happen in the absence of surfactant. Alveolar instability, collapse of small units, overdistension of large units, inefficient gas exchange, atelectasis. Surfactant solves this with remarkable elegance. Surfactant reduces surface tension, but critically, it reduces surface tension more in small alveoli than in large alveoli. As alveolar radius decreases during exhalation, surfactant molecules are compressed together. Surface tension drops dramatically. Collapsing pressure is reduced. The small alveolus is stabilized. As alveolar radius increases during inhalation, surfactant molecules spread apart. Surface tension rises. Appropriate recoil is maintained. Surfactant makes alveolar surface tension proportional to radius, equalizing pressure across alveoli of different sizes, stabilizing the entire lung. Laplace's law: P equals 2T over R. Small radius means high pressure. Surfactant reduces T as R decreases. Stability maintained. Question 4. Pulmonary surfactant is produced by A. Type 1 pneumocytes, B. Type 2 pneumocytes, C. Alveolar macrophages, D. Clara cells. The answer is B. Type 2 pneumocytes. Here's why. The alveolar epithelium contains 2 cell types, and they could not be more different in function. Type 1 pneumocytes, flat squamous cells, cover approximately 95% of the alveolar surface area. Thin and expansive, optimized for gas diffusion. Oxygen and CO2 cross through them. They are the gas exchange cells. Type 2 pneumocytes, cuboidal cells, cover only about 5% of the alveolar surface, but they are the metabolically active cells. Type 2 cells produce surfactant, a complex mixture of phospholipids, primarily dipalmityl phosphatidylcholine, DPPC, plus proteins and other lipids. Type 2 cells also repair alveolar epithelium after injury and can differentiate into type 1 cells to replace damaged cells. Type 2 pneumocytes are the stem cells and the factory of the alveolar epithelium. The clinical application: neonatal respiratory distress syndrome. Premature infants lack mature type 2 pneumocytes, insufficient surfactant production, alveoli collapse with each breath, progressive hypoxia. Treatment: exogenous surfactant administered via endotracheal tube, and antenatal corticosteroids to accelerate type 2 pneumocyte maturation in the fetus. Type 1, gas exchange. Type 2, surfactant production and alveolar repair. Both essential, neither interchangeable. Question 5. During normal inspiration, intrapleural pressure: A. becomes more positive, B. becomes more negative, C. equals atmospheric pressure, D. remains unchanged. The answer is B. becomes more negative. Here's why. At rest, end of normal exhalation, intrapleural pressure is approximately -5 centimeters of water. Already negative. This negative pressure is what keeps the lungs expanded against their tendency to collapse. During inspiration, the diaphragm contracts and descends. The external intercostal muscles contract. The thoracic cavity expands. As the thoracic volume increases, the intrapleural space enlarges. The lung is pulled outward by the expanding chest wall. The intrapleural pressure becomes more negative. approximately -7 to -8 centimeters of water during quiet breathing, even more negative during deep inspiration. This increased negativity does two things. It further expands the lungs, pulling alveoli open, reducing alveolar pressure below atmospheric, creating the pressure gradient that drives air into the lungs. Air flows from high pressure outside to lower pressure inside. The alveoli fill. In anesthesia and critical care, understanding intrapleural pressure is essential for interpreting central venous pressure and pulmonary artery pressure. These intravascular pressures are measured relative to atmosphere, but the transmural pressure, what the vessel wall actually experiences, is the intravascular pressure minus the intrapleural pressure. During mechanical ventilation, positive intrapleural pressure during inspiration can compress the great veins, reduce venous return, reduce cardiac output. This is one mechanism by which high PEEP can cause hemodynamic compromise, more negative during inspiration. That negative pressure is what breathes you. Question 6. The major site of airway resistance is A. Trachea, B. Small bronchioles, C. Alveoli, D. Medium-sized bronchi. The answer is D. Medium-sized bronchi. Here's why. This is one of the most counterintuitive answers in pulmonary physiology, and it is a board favorite because of it. The intuitive answer would be small bronchioles. They are the narrowest airways, and resistance increases dramatically as radius decreases per Poiseuille's law. But individual bronchiole resistance and total resistance are two different things. The airways branch extensively as they travel from the trachea to the alveoli. At the level of the small bronchioles, there are hundreds of thousands to millions of parallel pathways. When resistors are arranged in parallel, total resistance decreases dramatically. The enormous number of parallel bronchioles, despite each one having high individual resistance, creates a very low total resistance at that level. Medium-sized bronchi, by contrast, are fewer in number, less parallel branching, moderate individual diameter, higher total resistance. The maximum resistance in the airways occurs in the medium-sized bronchi, where the balance between individual airway size and the degree of parallel branching produces the highest total resistance. This also explains why early small airway disease, as in early COPD, can be clinically silent. Small airway resistance contributes relatively little to total airway resistance. Significant disease in small airways may not be detectable on standard spirometry until advanced. Medium-sized bronchi, maximum total resistance. The counterintuitive board answer. Question 7. During quiet breathing, expiration is primarily produced by A. Internal intercostal contraction, B. Abdominal muscle contraction, C. Elastic recoil of the lungs, D. Diaphragm contraction. The answer is C. Elastic recoil of the lungs. Here's why. Normal quiet inspiration is active. It requires muscle work. The diaphragm contracts and descends. External intercostals lift the rib cage. The thorax expands. Lungs are pulled open. Air flows in. Normal quiet expiration is entirely passive. At the end of inspiration, the inspiratory muscles simply relax. The lungs, which were stretched during inspiration, have stored elastic energy during that stretch. When the muscles relax, the lungs recoil inward. This elastic recoil compresses the alveoli, raises alveolar pressure above atmospheric, and air flows outward. No muscle contraction required. The energy stored during the stretching of inspiration drives the air out during expiration. This is profoundly important in respiratory physiology, because it means the work of normal breathing is almost entirely the work of inspiration. Expiration is free, but forced expiration, coughing, exercise, playing a wind instrument, is active. Internal intercostal muscles pull the ribs down and inward. Abdominal muscles push the diaphragm upward. Alveolar pressure rises rapidly. High expiratory flow rates are generated. And in obstructive disease, asthma, COPD, expiratory flow is limited by airway collapse and mucus plugging. Patients must actively use their expiratory muscles even for quiet breathing, dramatically increasing the work of breathing. Normal expiration, passive, elastic recoil. Forced expiration, active, muscle work. Question 8. Which condition is associated with decreased lung compliance? A. Emphysema. B. COPD. C. Pulmonary fibrosis. D. Aging. The answer is C. Pulmonary fibrosis. Here's why. Pulmonary fibrosis replaces normal elastic lung tissue with dense fibrous collagen. Collagen is stiff. Fibrous tissue does not stretch. The lungs become stiff, non-compliant. They resist inflation. A large pressure change is required to produce even a small volume change. Compliance, volume divided by pressure, falls dramatically. The consequences cascade. TLC decreases. The lungs simply cannot be inflated to normal volumes. FRC decreases. The stiff lungs pull inward more strongly than normal, shifting the equilibrium point inward. Work of breathing increases. Every breath requires greater muscular effort to overcome the stiffness. Patients adapt by breathing rapidly and shallowly, short, rapid breaths that minimize the work against stiff lungs. This rapid, shallow breathing pattern is the clinical signature of decreased compliance, restrictive physiology. The spirometric pattern, FVC decreased, TLC decreased, FEV 1/FVC ratio, normal or elevated. Because even though the lungs are small, airflow is unobstructed. What air there is exits quickly. Emphysema and COPD increased compliance, the opposite direction. Pulmonary fibrosis decreased compliance, stiff lungs, restrictive physiology. Question 9. Without surfactant, air would tend to flow. A. From large alveoli to small alveoli. B. Equally between alveoli. C. From small alveoli to large alveoli. D. Out of all alveoli equally. The answer is C. From small alveoli to large alveoli. Here's why. Return to Laplace's law. P equals 2T over R. Pressure inversely proportional to radius. Small alveolus, small radius, high pressure. Large alveolus, large radius, low pressure. Air flows from high pressure to low pressure. Without surfactant, air flows from the small alveolus into the connected large alveolus. The small alveolus, already high pressure, continues to empty, gets smaller, pressure gets even higher, empties further, collapses completely. The large alveolus receives the air, gets larger, pressure falls further, accepts more air, overdistends. The end result, collapsed small alveoli plus overdistended large alveoli. Atelectasis, shunt physiology, hypoxia. This is exactly what happens in neonatal respiratory distress syndrome, premature surfactant deficiency, alveolar instability, progressive collapse, profound hypoxia. Surfactant prevents this by reducing surface tension, especially in small alveoli, equalizing pressure across alveoli of different sizes, preventing air from flowing from small to large. Without surfactant, every exhalation would tend to completely collapse the lungs. With surfactant, the lungs remain stable at low volumes and reopen easily with each inspiration. Small to large, without surfactant. Laplace's law in action. Question 10. Which disease causes the greatest increase in alveolar dead space? A. Pulmonary embolism. B. Pneumonia. C. ARDSD, fibrosis. The answer is A. Pulmonary embolism. Here's why. Dead space is ventilation without perfusion. Pulmonary embolism is the classic dead space creator. A clot lodges in a pulmonary artery. Blood flow to that region of the lung is obstructed. Blood cannot reach those alveoli, but ventilation continues. The alveoli are still being inflated with each breath. Fresh gas arrives. CO2 is not delivered because no blood is arriving. No gas exchange occurs. This is alveolar dead space, ventilated alveoli with no perfusion. V/Q ratio approaching infinity. The consequences are measurable and clinically characteristic. EtCO2 falls because less CO2 is being delivered to ventilated alveoli. The exhaled CO2 concentration decreases. The gradient between arterial CO2, PaCO2, and end-tidal CO2, EtCO2, widens. Normally, this gradient is approximately 2 to 5 millimeters of mercury. In significant pulmonary embolism, this gradient widens substantially, sometimes dramatically, because a large amount of dead space is diluting the exhaled CO2. This is why a sudden, unexplained drop in EtCO2 without a change in ventilation in a monitored anesthetic patient should immediately raise suspicion for pulmonary embolism. The capnography saw it first. Pneumonia, areas of consolidation, perfused but not ventilated, shunt physiology, opposite of dead space. ARDS, combination of shunt and dead space, but not primarily dead space. Fibrosis, restrictive physiology, reduced lung volumes, not primarily a dead space disease. Pulmonary embolism, alveolar dead space, V/Q approaching infinity, EtCO2 drops, PaCO2 to EtCO2 gradient widens. That is 10 questions, mechanics of breathing. Your 5 things to lock in before you go. Compliance, volume divided by pressure. High compliance means easy inflation. Low compliance means stiff lungs. Decreased in fibrosis, increased in emphysema. FRC, equilibrium of inward lung recoil and outward chest wall recoil. Lung inward force equals chest wall outward force. Laplace's law, P equals 2T over R. Small alveoli have highest collapsing pressure. Surfactant reduces T as R decreases, stabilizes all alveoli equally. Normal expiration, passive. Elastic recoil alone. No muscle work required. Forced expiration is active. Pulmonary embolism. Greatest alveolar dead space. Ventilation without perfusion. V/Q infinity. EtCO2 drops. PaCO2 to EtCO2 gradient widens. I'm Anesthesia Buddy. Stay sharp. See you in the next one.